Good afternoon. Thanks for joining us today for February's Ask an Expert Anything Expert Panel discussion. We took January off, sort of. We've been doing this now for a little bit over a year. And today's topic is going to be ventilator-induced lung injury. We'll start out by introducing ourselves real quick. Tom?
My name is Tom Prano. I'm a respiratory therapist from Canada.
John?
John Encrott, flight respiratory therapist, Advent Health, Orlando, Florida.
My name's Keith. Keith Lamb, Centara Martha Jefferson Hospital in Charlottesville, Virginia. Madison?
I'm Madison Fratsky. I'm a respiratory therapist at UVA in Charlottesville.
Eric?
Eric Reiner. I'm at MedStar Washington Hospital Center in Washington, D.C.
Sarah?
Hi, I'm Sarah Bazalik. I'm a respiratory manager at Advocate Aurora in Milwaukee, Wisconsin.
And Andy, the fresh haircut.
Good afternoon. Andy Klein. I'm a respiratory therapist and clinical educator at Rush University Medical Center in Chicago.
So welcome to all our panelists. I don't usually do this, but I want to just give a brief overview of how we sort of got started with this. Everybody you see on the screen here are fairly close friends and colleagues, and we've known each other for a long time. We have all been involved pretty in depth with education and clinical practice, and we've traveled, some of us out of the country, and we are just really good friends, and we like to talk about respiratory critical care. So we got together and we just started to do these panel discussions, and then started to get a little bit more organized and advertise them. The beautiful part about it, I think, is that we don't charge anybody any money. There's absolutely no expenses. We're not supported by anybody, any outside source. As a result, there are no CRCEs involved or professional credits, because I would have to write a check for those. And so we just appreciate the fact that this is a sort of a informal discussion about important respiratory topics. And so I appreciate all the volunteer time that all the panelists have given us over the last year plus and today. So as I said at the very beginning, our topic this month is ventilator-induced lung injury, and we sort of came up with this topic because we know that it's very important in our daily clinical practice. I'm going to give just a real brief overview of VILI real quick before we get started. People have talked about damage caused by positive pressure ventilation for a long time. If you look up the history of VILI, you'll see even in the late 1700s where people were starting to produce mechanical devices that would help with ventilation. They realized that when people did mouth-to-mouth resuscitation, it was probably less injurious because there was more control and feedback with the person performing the ventilation. Fast forward to like 1960s, primarily, we started to really understand post-mortem analysis of lungs. We started to understand that there was more pathology involved than should have been expected from the initial insult or disease itself. And so people started to talk about how the ventilator probably was part of that. You fast forward to even the year 2000 in the ARSNet trial, the ARMA trial from the ARSNet group that compared tidal volumes, 6 milliliters to 12 milliliters, realized that lower tidal volume was associated with lower mortality. So VILI, or ventilator-induced lung injury, by the way, you also see this in the literature referred to as ventilator-associated lung injury. And I don't know that there's I think they're fairly synonymous, and I think that typically people are talking about the same thing. And that is volutrauma, barotrauma, adduct trauma, and biotrauma. When I do an ARDS lecture, I always talk about mortality in ARDS. And if you're familiar with the LongSafe data, that's a few years old now. It was around the world, Northern Hemisphere, Southern Hemisphere, everywhere. And the realization was that it didn't matter if you were in Charlottesville, if you were in Florida, if you were in Canada, Chicago, it doesn't matter. Moderate to severe ARDS still has a 40% mortality rate, no matter where you're at, right? And so I think it's important to understand that when you break down that 40% mortality rate, that, and given that most of the people that are intubated and placed on a mechanical ventilator with ARDS are intubated because of acute hypoxemic respiratory failure. And when you look at the mortality data and you break that down, only 1 out of 10 of that 40% that do not survive ARDS actually die of hypoxemic respiratory failure. Most of them don't. About 90% of them, of patients who do not survive moderate to severe ARDS, is not because of hypoxemia. It's because of multi-system organ failure, right? So when you dive back down into it even a little deeper and you look at what is it that causes that multi-system organ failure, it is believed, and I believe also, that the great majority of that is caused by the ventilator. It's caused by positive pressure, and this can be either invasive or non-invasive. We should be approaching our management in both of those scenarios similarly. So that's sort of my real brief overview. And I think what today we're going to look at is we will look at some of the pathophysiology probably, but it's important to look at the data and to ultimately see what it is that we can do to mitigate the incidence of ventilator-induced lung injury.
Just to add to your comments, Keith, I've shared a nice graphic that I like to demonstrate sometimes in lectures regarding how patients are managed with their criteria. I know this is based on the Berlin definition of ARDS. That was the most relevant version when this got published. And you can see the graph here represents tidal volume in mils per kilogram of predicted body weight and plateau pressure. And what we know of ventilator or preventing ventilator-induced lung injury currently, the best evidence we have, of course, is to use, and I hate the word low tidal volume, because if you start reading about tidal volumes, you realize that normal tidal volumes in a mammal are 6.3 mils per kilo of predicted body weight. So if we're using normal tidal volume of 6 mils per kilo, this is considered lung protective, and then plateau pressure is less than 30. And what this graph shows you is the distribution of patients with mild, moderate, and severe ARDS, and you can see how you can see how many patients are above 8 mils per kilogram of predicted body weight across all criteria of ARDS. And then, of course, patients that also are above that in tidal volume and plateau pressure, there's significantly less, but there's a significant number that are still maybe within the tidal volume range, but still with plateaus above 30. So, we're not perfect. It would be great if all of this was under here, but of course we've all had very complicated patients where this may be difficult. All right, who's next?
I'm trying to send you an image that I'd like for you to pull up here in a few minutes when we get to that point.
Oh, you should be able to share, but where did you send it? My text or email?
Well, I didn't send it yet.
Okay. You can try sharing if you want.
Why don't I do that? Just let's see here.
Or tell me what it's from and I can call it up too.
It's out of one of my talks I just did.
Okay.
I'm going to email it to you. In the meantime, Eric, you want to add anything so far?
Sure. So that's a terrible report card, right?
Yeah.
If you kind of think about it, mortality still stings, and our application of what we know to be true or what we think to be a recipe for success still isn't followed by a lot of people, right? I don't have it right off of the tip of my tongue, right? But do we, so if we're overdosing these patients, right? So there was significant numbers of patients that were receiving greater than 8 cc's per kilo in the tidal volume, which would be that bottom right? So it makes me wonder, even from kind of an institutional standpoint sometimes, right? Because it's a big place where we are. People get missed sometimes, possibly, right? Do you guys feel that either we're overdosing them because we're not getting predicted body weight correct, right? We see a patient that maybe is morbidly obese, and we're not dosing volume correctly to a predicted body weight, or is this unrecognized ARDS, right? That in retrospect, yes, the patient had it, but we didn't recognize it, and so we were putting it there. We were putting the volumes outside of the range. Like, so within our practice, what we have really kind of driven and drilled down into, just from a quality assurance and data perspective, is that we overdose female patients quite often, right? The female patient, just kind of gets, I think it is, they have to be, if you just pick the random volume of 500 that a lot of people just love to start at or whatever have you, fine, you'll capture a lot of male patients with that and be in an acceptable range. But if you pick 500, that female patient has to be greater than 5'9" tall, I think. And so the average female doesn't work for you, right? And so this was years and years ago, right? And so we were like, look, you got to think about this. This is the data. This is what you're doing. This is where we're messing up, right? And so it just makes me think about reasonings why, we've defined
Eric, I think the current evidence, as you suggested, points out that we're not measuring patients, so we're choosing tidal volumes that are typically making us comfortable, and we're not perhaps recognizing that patients are meeting criteria for ARDS despite the fact that they are. The other thing for sure is the misdosing of based on sex. This is for sure an issue. One of the, I believe, and I'm sure someone here in the panel may have been at the late Bob Kazmarik's talk one year. He was talking, I can't remember what lecture he was giving, but he said, if you just want to remember two numbers, he says, for the average size male, 450, for the average size female, 350, and then work from there. He's like, if you don't have a tape measure on you, you can just start with those and go get your tape measure, but you're going to likely be a very similar or safe range. So when you say 500, I agree. A lot of people might choose 450 or 500, but that would be a large tidal volume for specifically or particularly for a female patient. Yep. So this is important, but I constantly remember that it was like a pearl of wisdom. And then when you look at charts of predicted body weight and the average tidal volume, you realize that there's, for a large range of heights, and again, based on birth sex, you can see that 350 is in around 6 mils per kilo for a significant range of female, and then the 450 for a significant range of male patients.
Yeah, that was like a decade ago. Now we have, there's tape measures on every unit, and it's just much more strict. But, within, just kind of as you go into ventilator, the entirety of the topic, I think you kind of arrive at the first step is, are we recognizing it, and how are we kind of prescribing what we're doing, right? And that graph kind of clearly shows you that there is a problem, right? And
it'd be nice to get some feedback from the attendees here. Sorry, Sarah, before you mention,
that's
just want to get some of the attendees to sort of document whether or not they feel that height is measured routinely, or if it needs some work in your organization. And of course, we're not saying you need to do it more. You probably do it all the time. That's why you're here listening to our presentation. But just let us know if you feel like it's underutilized. Like, are patients routinely getting their height measured for accurate tidal volume delivery, or is this something that needs some work in your organization? And again, you don't have to say where you work, so you don't have to point any fingers. Just say, I think we need some work where, where I practice, or we routinely do it. We'd just like to know if you I know in the city I work in, we have one major hospital, and it is routine to actually measure the patients with or without ARDS. Generally on admission, they will do that.
One thing I was thinking, Eric, when you were talking earlier too, is in my previous role as a respiratory practice specialist, I would often, when I was teaching what our target goals were for most of our patients for volumes, is people were so thrown off that I knew my own ideal body weight. I'm like, well, why would that be odd? And I already knew what my height required for my preset range. And I really tried to get people to think about that, because we do think about how is the patient comparing to our height and things like that. And I think that really helps set people in a perspective of starting to be a little bit more objective of that and thinking ahead of time. If you know yours, you can range it right off the bat. Then for others, they're going to be a little higher, they're going to be a little less. And then having those targeted ranges presetting your head for female and male really helps them be more accurate.
I think a couple other things, just to expand on what Eric was saying. You made a lot of great points there, Eric. I think two things. Up until 2023, when the new ARDS guidelines came out, or the new ARDS definition, I should say, it was kind of hard to diagnose ARDS, because if you couldn't confidently rule out left heart failure and or cardiogenic pulmonary edema as at least a major cause of the chest X-ray and the hypoxemia, then people were hesitant to hang that on them and thus start the cascade of therapy that needed to happen until, maybe the next day when you could do an ultrasound or whatever the case may be. And then the other point I was going to make related to tidal volume is, I think that there's still this, in a lot of places, I think there's still this desire to normalize ABGs. So even if you land on the right tidal volume initially, once the gas starts to get away from you, there's this instinct to turn the tidal volume up once you've gotten to a place on the rate that you don't really want to go over for whatever reason. And then you just turn the tidal volume up to get back into that, 735 range. I talked to a student recently that they came, and said, you told us tidal volume's, more important, but this place was, I basically got yelled at for even bringing that up. We need a 735 ABG, because why would we take poor care of the patient by letting their ABG not be normalized? So, I think there's a lot of places that still have that stigma of, a normal range ABG is important or more important.
And the insanity continues, right? Like Eric had said, poor report card, and that people still don't practice what should be practiced. And to dovetail this onto a transport perspective, I look at Nick Moore's group out of Iowa in 2015 and Michael Allison's group out of Maryland in 2015, and both showed, in Moore's group, they looked at tidal volumes in transport and how those went over into the emergency department. And Michael Allison's group showed that high tidal volumes in the emergency department translated into the ICU. And of those who developed ARDS within 48 hours, they had higher tidal volumes of at least 1.5 mLs per kg. So why are we not doing this better? Why are we not able to tackle this and, to have a better survivability than 40% mortality? And Keith nailed it when we talked about, bacterial translocation and what that does to other organs and how that's affected by high tidal volumes and lung injury. So, we are the front line. We need to be doing this better and educating folks, continuing to educate folks. And, we talk about the fireman squeeze of an ambu bag on an endotracheal tube with a 1600 volume in an ambu bag. And it's like, why are we doing this? And there's literature out there now that supports using pediatric BVMs for adult patients because their tidal volumes are adequate. So just some 2 cents in how that transpires to the transport world. We've also gone into facilities and seen incredible ventilator mismanagement as recently as last week, when a colleague of mine went to a facility who had a patient. A gentleman was like 5'10". The tidal volume was at 600. The respiratory rate was at 40. The I time was at 0.5. The peak pressures were 51. And that's just mismanagement. And that person could be hurt with those parameters. So again, need to be doing it bigger and better. And I'm curious what the panel thinks about, and maybe Tom, if you have one of these things pulled up, about mechanical power and how does that relate into lung injury, and what can we tell the attendees about that? Is it something we should be looking at, or is it something, because it lacks RCTs, that maybe we don't carry as much weight with that?
You went all the way to the end.
Yeah, I have I have some strong opinions about mechanical power. Do I agree that it correlates with mortality? Yes. Do I think we struggle enough getting RTs to do basic measurements like plateau pressure? Yes. Do I think adding mechanical power to the equation is required or necessary? No. In fact, if you measure driving pressure, you have sufficient information to tell you the risk of outcomes in your patients. Again, it's an associative outcome. I want to point that out. We don't know if targeting driving pressure is better for outcomes at this point. We just know that there is an association. So, of course, sicker patients will have higher driving pressures. Whether we mitigate or take steps to improve driving pressure still requires further data. There's some nice emulated data coming out of a group in Toronto led by Dr. Martin Erner. That's, that they're taking essentially emulation trials. It's very cool, like AI machine learning type stuff, but they're also suggesting that perhaps limiting driving pressure is a beneficial strategy, but we don't have prospective studies right now that have targeted it. And the other question we don't know is, how do we mitigate driving pressure? Because you can lower tidal volume, or you could try PEEP titration, and we don't know what the best effect would be. We don't know if changing PEEP to improve driving pressure causes other issues. We don't know if it will increase atellect trauma. For example, we know that decreasing PEEP can improve compliance in many patients, but you get to a point where the lowest driving pressure might not be the best driving pressure, because there may be some tidal opening and closing of alveoli when PEEP is set too low. So compliance can be high, but you still have collapse occurring at the end of exhalation. So in terms of what we should look at, driving pressure is the easiest and simplistic. And I do have a good paper here. Let me bring it up, and I'll link it in the chat as well. But this is the one that I usually go to when I say I have strong opinions about mechanical power, but when I suggest that that's more than you need to do. This is the paper that I typically reference. So this paper, let me just get up to the title here so that you can see. It's ventilatory variables in mechanical power in patients with acute respiratory distress syndrome. A lot of really, high profile authors here. We've got Costa, Slutsky, Burchard, Brower, all the way down to Gallagher. Marcelo Amato did the driving pressure paper. We have what they presented, and this is what I like to show many times, is that when they take the single variables that are associated with mechanical power, some of the ventilator variables, you have respiratory rate, tidal volume, driving pressure, PEEP, and plateau. And if you're not familiar with forest plots, when this line crosses this dotted line, there's no significant basically loses significance. So plateau pressure does not tell you by itself that there's a problem. PEEP does not tell you by itself that it's a problem. Tidal volume does not tell you there's a problem by itself. Respiratory rate and driving pressure actually are single ventilatory variables that are associated with mortality. And I'll get more to that in just a moment. And actually, this plateau, PEEP, and tidal volume was actually covered in the Amato paper. If I show you the Amato paper here, you can see they have this really nice graph where it shows patients that were stratified for PEEP. So patients with similar PEEP but different driving pressures, they actually had worse outcomes the higher the driving pressure was. And even though plateau was higher, so plateau pressure was not associated with it, it was the driving pressure, because here they regulate or they standardize for plateau pressure. And you can see patients with lower driving pressure, and the only way you would achieve that is by having higher PEEP. But these patients had a lower mortality than those on lower PEEP with the same plateau. And then these are patients with the same driving pressure, and you can see there's no impact on outcome. And this outcome here is the multivariate relative risk of death in the hospital. So when you look at this data here, this again suggests that, yeah, these three variables don't matter much. So they're all in the mechanical power equation. Now, when it looks at total power, you can see, yes, it is associated with mortality. I'll scroll to the bottom so you can see this is odds ratio of, and this is looking at mortality is the outcome. Some mechanical power is associated with it. But when they broke up the power components into the elastic or driving pressure related components versus the PEEP related components, and then the related to flow and airway resistance, you can see the only thing that still stands out as related or associated with mortality is those elastic derived power components. And then this is the nice thing that I found. When they looked at driving pressure times 4, because they actually found driving pressure to be 4 times worse than respiratory rate. And this is actually a really good discussion. If you have to think about which parameter you should I change the respiratory rate or should I try to adjust driving pressure? Driving pressure has a stronger impact. So the effect is 4 times greater than respiratory rate. But when you combine these two variables, there is a very strong association with outcome. So what does this look like clinically? And they actually have a really nice graph down here that I share a lot. So this is driving pressure and this is respiratory rate. And you can see that there's a significant, so respiratory rate is rather linear and driving pressure has a little bit of an exponential curve here. So you can see the driving pressure, again, is 4 times worse than respiratory rate. But how would you use that clinically? This graph is a really nice graph explaining isocapnic conditions. So what does that mean? If you had to make ventilator changes to adjust respiratory rate or tidal volume / driving pressure to achieve the same exact CO2, okay? If you had a patient with low compliance, so 14 mils per centimeter water, this is the red line here. Let's say this is the patient with a driving pressure of 27 and a rest rate of 30, and you were able to make adjustments that brought that driving pressure down to 21. But in order to do that, this is, again, you're lowering tidal volume. So look at the tidal volume here. We're close between 5 and 6 mils per kilo. If you were to lower it to just above 4 mils per kilo, this drop, you would have to increase the rate to 45. But your odds ratio of death actually decreases. In a patient with good compliance, it's not the same effect. If your driving pressure was 12 at 6 mils per kilo and your rest rate's 25, if you were to lower tidal volume to get a lower driving pressure, again, 12 is not considered to be bad. 15 is usually the cutoff that many people use. If you were to lower it to 9, and in order to do that, by dropping your tidal volume, you had to crank up your respiratory rate to 40, there's actually an increase in your risk, right? So this is sloping up, this is sloping down. So 2 different conditions, 2 different scenarios. Essentially what the study is saying is that if you're lowering driving pressure, it's only beneficial in patients that likely have worse compliance or hence higher driving pressure. And the variable, there's no threshold as like what's good or what bad. The whole idea is that if you take that driving pressure times 4, let me go back up to the equation, plus respiratory rate. If you take that, when you make ventilator changes, if that number is going down, that's beneficial. If it's going up, this is a bad thing. I hope I didn't take too much time to explain that.
Could you say that again, Tom? I'm sorry.
Don't tempt me with a good time.
Don't tempt me. I know you're ready. I know you're ready to do it again. So let me just add on. Let me just slow down just a little bit and make sure that the points that we're trying to make here are being understood. So, Andy, you made a really good point about ABGs. I think it was Andy that weren't you talking about blood gases and making them correct? I am in complete agreement, and I believe that we cause VILI by trying to ventilate people to achieve better ABGs. We know that from the data and from our own experiences that people tolerate, to some extent, acidemia fairly well. And if, there are some patients that tolerate it better than others, like an asthmatic, for instance, will come in and will have a CO2 of 150 and a pH of 6.8. And as long as we don't hurt them with the ventilator, a week later, they're walking out the front door, right? And so that's one patient we would for sure not try to fix the blood gas on. People who are multi-system organ failure are a little less tolerant. If they're on like triple pressor, if they're really hypotensive and in shock, and they don't enjoy being acidemic as much. And so that's a person that you would always stand there and evaluate the risk and the benefit for, right? But what we're talking about primarily is ventilator-induced lung injury. And, we don't understand completely. People react to ventilator-induced lung injury or to potential things that cause VILI differently than others. And I think that you'll, from the standpoint of most physiologists, will tell you that it's sort of DNA dependent, right? One person will tolerate it a little better than somebody else. It's sort of, when I teach this concept, I talk about bee stings. You know, like if I get stung by a bee, I just get agitated by it. The person standing next to me might get stung by a bee and it killed them, right? So they have an exaggerated inflammatory response to that bee sting. People have an exaggerated inflammatory response to the ventilator settings that we're using to sort of support them. I agree with Tom, mechanical power and others. I don't think it's as important to try to get the entire equation understood by every RT. I think it's important that everybody understands what manipulates that mechanical power, though. If you think about what, and you explained this very well, Tom, but when you think about mechanical power really being just the amount of energy that you apply to the lungs, and the lungs not being used to having energy applied to them, regardless, even if they're completely healthy. And you think about, so what is it that I do with the ventilator that increases the energy applied to the lungs? And, you know, driving pressure, tidal volume, rate, those kinds of things. I wanted to just talk a little bit more about Amato's paper. And by the way, if you really want to hear his opinions and his concepts explained very well, just go to YouTube and search for the Amato driving pressure lecture. And it's about an hour long, I think. He's somewhere, maybe at ERS or somewhere, lecturing about this. But the thing I want you to also understand about his paper and driving pressure is that, just like Tom drilled in a little more deeper about, but also if you think about PEEP, right? PEEP. If you some of that subset data that he presented showed us that if the driving pressure goes up and you have done nothing at all with the PEEP, that increases mortality. Like PEEP is at 10, driving pressure is going up, or you make changes that make the driving pressure go up, the mortality increases. If you increase the PEEP, but the driving pressure does nothing, then that has no effect on mortality. Mortality is about the same. If you increase the PEEP and that leads to a decrease in driving pressure, probably recruited alveoli that were non-functional. If that decreases driving pressure, survival improves. And then finally, if you, as a driving pressure gets closer to 15 and more, then mortality gets worse.
Hey, Keith, real quick.
Yes, sir.
Real quick. So I guess my question is to the panel and to the attendees that maybe want to know more is, should we be putting more emphasis on driving pressure? Are we not putting enough emphasis on that? It's not in the definition of ARDS. It's not on the ARDSNet trials. You know, ARDSNet was disbanded in 2013 for PedalNet, and this paper came out in 2015. So do we need to put more focus on driving pressure?
Tom, can you pull up that slide that I sent you? Did you get it?
Yeah, I have another article that I can show that shows something different or similar, unless you needed the text at the bottom of it. But essentially, you're showing the baby lung, right? This idea here. Yeah. So this one might work because this also goes to your point that if you increase PEEP, like this is a patient where the collapse at 5 centimeters of water and 45 centimeters of water of pressure. Again, this is just like a sustained pressure. You can see there's not much different. This is not a patient that responds to PEEP. So increasing PEEP in this patient is likely just going to increase your driving pressure. In this patient, increasing PEEP opens up areas. It may reduce driving pressure, but you have to remember PEEP is always a balance between overdistension and collapse. So the improvements in compliance down here may balance or not be as beneficial as the potential for injury that may be occurring. So sometimes you can increase PEEP, sometimes driving pressure doesn't change. It could be that you're now trading recruitment with overdistension. So this is really one of the challenges of just adjusting PEEP and looking at just compliance and driving pressure, is that some areas compliance will get worse and other areas compliance will get better. And sometimes the net result of what you see is just nothing is changing, right? And so the question comes down to what is worse, over distension or collapse? And that question still needs to answer, but I think most people are leaning towards over distension. But yeah, does this graphic work, Keith, or do you want me to pull up a different one?
Yeah, so what I wanted to show, if you could can you pull up that one I sent this?
Yeah, I'll try to, I just need to, because I'm trying to, there's not a picture for me to, it's either slides or not slides. So let me see if I can open this in.
Actually, I can just use this. I can just use this. This is fine. So if you're looking at this slide with these CT slides, this is a high resolution CT scan that they've taken here. And if you let's say that let's say this patient right here on your left and this patient right here on your right are both 5'9" males. Okay, 5'9" males. If you look up the predicted body weight chart, a 5'9" male should get about 424 milliliter tidal volume, I think. Let's say that's correct. So if I'm managing both these patients and I put 424 milliliter tidal volume in that picture that just went away.
No, I just got you a new one. There you go.
Okay, cool. So yeah, this is the one that I was. So 424 milliliter tidal volume, 424 milliliter tidal volume. Clearly, if I don't do anything but manage this patient via predicted body weight, and by the way, that there are a couple people in the audience that have mentioned using weight. I have to assume that you're talking about babies or real young children who probably weigh what they're supposed to weigh. But in adults, we use predicted body weight because the lungs inside of a person that's got a BMI of 50 are not smaller than a person or bigger than a person who has a BMI 25. That doesn't mean that the ventilator strategy wouldn't be different. We could talk about transpulmonary pressures, et cetera, but we're talking about tidal volumes, and those should be based on predicted body weight. So anyway, if these were two different patients, 5'9" males, and I put this person on volume control of 424 and this one on volume control of 424, clearly the plateau pressure, the driving pressure, the stress, the strain, all of the things that we are concerned about in terms of ventilator-induced lung injury will be worse in one of these patients than the other. Am I right? Eric?
Yes.
Yep.
Yes.
So I just want to make sure these are the guys who I call to ask on a daily basis. Am I right? Am I thinking about this right, Tom? John,
I mean, and this is the concept of the concept of driving pressure is tidal volume, essentially
functional lung size.
It's based, so it's tidal volume divided by respiratory system compliance. So in the patient on the left will have a different respiratory system compliance than the patient on the right. So putting the same tidal volume, your resulting driving pressures will be completely different and will reflect the size of the lung you're trying to put that volume in. And this value of driving pressure of 15 just happens to be the cutoff value that was found in a study that looked at a large database of ARDS studies and took plateau minus set PEEP. Now, some of the criticisms and people moving forward are now measuring it with total PEEP because there might be 1 or 2 centimeters of water of total PEEP. There's an ongoing study called the Prevent VILI study. It's essentially EP-Vent3. So it's an esophageal balloon study for setting PEEP, but they're no longer using esophageal pressure to actually limit plateau pressure. They're using driving pressure, and their cutoff is 12. Now they're measuring total PEEP, so it's plateau minus total PEEP, and their cutoff, they're going to try to reduce either tidal volume or adjust PEEP. I'm not sure their entire protocol, but their goal is to limit driving pressure to 12 centimeters of water or less.
And Tom, this picture that you keep put up there, this kind of relates back to that paper you just showed, right? The graph. So the one on the right is going to be the one that you want to decrease the tidal volume and turn up the rate to improve your outcome, and the one on the left is going to be that bottom graph where the tidal volume staying on the normal 6 ml end and leaving the rate at a more normal rate is going to be more beneficial. Right?
Or even lower. The one on the right is going to have significantly higher driving pressure and likely will respond more to reductions in PEEP if they're not PEEP responsive, and reductions in tidal volume. because the space is just, again, it comes down to recruitment potential, right? And that's what that Gattinoni paper was showing, is just the potential for recruitment. This really indicates what your response to PEEP will be, but it's the same with tidal volume. It'll be the response to tidal volume. If you're increasing PEEP and all you're doing is over distending, this is obviously not a beneficial. The patient's non-recruitable. For patients who are recruitable, there may be a benefit, but it's, again, I always point out that PEEP is always a compromise. So sometimes we try to optimize PEEP on things such as compliance or whatnot, but the compliance that's being shown to us on the ventilator is a compromise. It doesn't tell you how much of that compliance is because of an area of the lung that's over distended or an area lung that is better. So improvements in compliance might mean a good thing, but sometimes they can mean that you have more collapse. And this, reason why I'm saying this is just after years of experience with electrical impedance tomography, you start to learn that the respiratory system compliance really doesn't represent what's going on in the different regions of the lung, because it's such a heterogeneous process. ARDS, we don't, it's not, the whole lung is not affected the same. This baby lung, or these areas that are already open, are prone to being over distended when we apply either higher tidal volumes or higher PEEP. So to get back to the question you asked, and I think, John, you were the one that asked it, like, should we be looking at driving pressure more closely? And I think the correct answer is we should be monitoring it, and we should be assessing it for changes after we make changes on the ventilator. But in terms of how to utilize it, that question really is still up in the air. We don't know if the lowest driving pressure is the best. As I mentioned, you could get a driving pressure of 9, but maybe for that patient, it's actually not a beneficial move to lower tidal volume or lower PEEP to get this best or lowest driving pressure, because there might be atelic trauma occurring. We don't know. So is the question just to limit it to 12, 14, or 15 and just keep it there? Because again, if we go by the driving pressure study, tidal volume doesn't matter. So maybe if we can give a patient 8 mils per kilo of predicted body weight with a driving pressure of 14, maybe that's okay. They'll have better blood gases. Will they have injury? According to the data, there's not a clear association between tidal volume and injury. And even in the ARDS guidelines, when they talk about their recommendations for using 6 mils per kilo of predicted body weight, it's actually an expert opinion. We don't have evidence that 6 is the best, that 6 is better than 7, that 7 is better than 8. We actually don't. We know that 10 and higher is associated with bad things, but we don't know if 6 is perfect or 7 is perfect. And I think the answer to that question comes down to, well, what's the resulting pressure in the lung? I mentioned Dr. Martin Erner recently. I think I saw him give at least 3 different lectures at this conference in Kuwait that I was at a week ago, and he was suggesting that dynamic pressure is even useful. So if you use pressure control as a mode, your dynamic driving pressure is your pressure control level, right? So 15 centimeters of water of pressure control, that's a dynamic level. And they found that a dynamic driving pressure of 15, if you can maintain 15 or less, it's optimal. So again, a future study could say, okay, let's see if we can manage patients with a pressure control of 15. Who cares what the tidal volume is? If the tidal volumes end up being high because they have good compliant lungs, then you can lower your respiratory rate. If the tidal volume is low at 15, you may need to increase your respiratory rate. But again, we don't have prospective studies to tell us that's the right thing to do. So again, to get back to the answer of your question, I don't know that we know what to do with the information, but we definitely should be at minimum documenting it and trending it over time. And someone in the chat said that, or I think it was Madison, asked whether or not you trend driving pressure. And I think this is a very useful tool. And we've talked about a number of things like P0.1. There's a number of values that we may not know exactly what the right answer is to what to do about it, but we should at least be beginning to monitor these things because we think that they're important signals that something is maybe going in the wrong direction.
One thing that keeps coming up to mind for me too is we're giving thresholds, right? But as you just said, we don't know the clear association for how that's going to be for each individual. And I think that's one of the pieces is we have to start thinking about looking at how our patient is interacting with the ventilator. And that's a whole topic we haven't even talked about is what does the work shifting look like? What is our ventilator desynchrony looking like? Because those are pieces too that are going to impact our measurements. But if we don't recognize that it's maybe the patient is taking on a lot of that work so that compliance looks falsely high, we need to be assessing how that's going and not just plugging in numbers. We need to understand what's happening and use our clinical assessment skills too.
Tom, there's an interesting question in the chat. I don't know if you saw it yet, but
yeah, I was just going to ask if it's okay if I pull up some questions. Are you talking about the last one there?
I've often wondered that, and we've had some debates in the ICU about that. Is if you see an initial sort of negative response, is that just because you didn't give it long enough to to settle in, so to speak, where that pressure had more time to distribute before you saw the end result?
Yeah, I think this is a good question, because then it comes down to not only recruitment potential, but what about time, right? Like, does the lung take more time? You have to understand that the longer the lung takes to recruit, the longer you're over distending the lung if the changes you made in PEEP had an immediate negative impact. So the question is, will you see an impact in driving pressure immediately? Yes. I'm not saying it won't change. So for example, if I increase PEEP in a patient who has bad lungs, the driving pressure may increase. So the question is, but will it go down in an hour if the patient continues to recruit? And it might if they recruit. But in the meantime, you have to understand that you're over distend. If your driving pressure went up, you're likely causing more stress and strain in the time it takes to potentially recruit. So it becomes we don't know what the right response is. Do you wait it out? I would say that if you increase PEEP and your driving pressure doesn't reduce in a reasonable amount of time, how much time that is questionable. Some people say it takes less than 10 minutes to recruit a lung if you're applying the right pressure, like not sustained, but like ventilating patients out of pressure. Should it take 2 hours, 3 hours? Again, we don't know the exact answer, but if it took 3 hours for that driving pressure to come down, that's 3 hours of over distension. If the response to PEEP was a negative response of driving pressure increasing. And then same with going down on PEEP. You may go down on PEEP and your driving pressure may improve. And then maybe a few hours later, their driving pressure is back up again. What does that mean? Does that mean that PEEP is still now too high for the patient? Are they being actively diuresed? Or does it mean that there was collapse that's no longer reopening? If driving pressure comes down, does it mean that there's actually collapse and reopening? Like, there's so many variables we don't know when you're just looking at driving pressure. So it's a very difficult question, to answer. I think many of the times that we optimize PEEP, I'm just going to throw this out there, I think we're too slow to wean PEEP after we optimize it. No one wants to break the patient. No one wants to decrease. So I think sometimes patients are left on elevated levels of PEEP beyond what they should be, because we don't really know what the best answer is. How do we titrate PEEP and look at driving pressure? There's a great paper published in Respiratory Care. It's sort of a feasibility study on managing PEEP and the response to PEEP based on driving pressure. I'll call it up in a moment. But again, it's a feasibility study. We don't have a prospective study to suggest that adjusting PEEP and monitoring driving pressure is actually beneficial. And it could be because of these time variant. Like there's a time component where it may take more time to recruit, but during that time you're over distending. So does the eventual benefit outweigh the risk of 3 hours of worse ventilation? We don't really know.
Tom, you brought up a good point.
Let anybody else continue while I look for this paper. Sorry, go ahead, Andy.
Yeah, sorry. I was just going to jump in before we got too off track of the point you just made. So you mentioned, we turn the PEEP up, we optimize it, we do whatever we do to get to where we park, if you will. 24 hours goes by, 48 hours goes by. Like you said, no one wants to rock the boat. But the thing is, there's changes happening within the disease process, right? The disease process is still sort of dynamically, you get worse, you get better. And if you're not assessing that, if you're not looking to see if overdistension occurred as a result of just leaving the PEEP alone, I think that becomes a thing, because I can't tell you how many times I get called to a room because a patient's desatting. I see that they've been on a PEEP of 16 for 4 days. I go down to 14, their sats immediately go up because there was this occult overdistension that occurred just as a result of not continuing to find where that optimal PEEP is as the disease process changed. So I think, one of the things I've started kind of talking to my staff about is, hey, you're not gonna lose anything by just moving it a little bit and seeing if there's a difference, right? Go down by 2 and see if the plateau drops by 5 centimeters of water pressure. Go up by 1 or 2 and see if the plateau jumps. See if where you're parked is a good spot or not still, because things change over the course of days and even hours sometimes.
So what I say to that, India, and I say this all the time, we're really good at getting into things. We're terrible at getting out of them. Like we're really easy and quick to go up, and just like what you're saying, here, and I'll just kind of give you my slant on my answer to this question and my qualifications for it. So, and the words that come out of my mouth is what's our goalpost? Like what's our time frame? What's our goalpost for assessing whether what we just did with this PEEP is okay or not, right? And what that discussion then leads into is, have we done the RI, and are they recruitable or non-recruitable? If they have a great RI proving recruitability, I'm much more tolerant, right? Like that goalpost can then move outwards. Clearly, if they have no potential for recruitment, then there's zero tolerance for this change in PEEP, right? And then like we often talk just simple stuff that impacts the recruitability of the lung. Where are you within this disease process? Are you day 1 or are you day 5? And what are you trying to do at that present time? And is this intrapulmonary versus extrapulmonary? All of these things that get wrapped up in the recruitability of the lung. I think, at the end of the day, for me, is what is going to determine the length of my goalpost in terms of timing, and my allowance and my degree of patience, essentially. All right. And so if I have an intrapulmonary process, day 3, we're behind, we're getting our butt kicked. And I got a terrible RI ratio. And I go up on the PEEP and the driving pressure starts to spread out on me, I'm done. I'm not going to be, like, my recruitment potential is pretty low, and that timing is really short for my patients. If I'm septic and I'm early in this, and I have an RA ratio that's approaching 1, and like things look good, and I go up on that, up on the PEEP, and the driving pressure spreads out, that goalpost is a little bit more generous, right? Like, all right, let's come back and let's regroup, and we'll circle back around in an hour and see if the drive came back to us or not, as we're trying to figure that out. And so I think what you're getting into is this kind of individualized approach of this application of PEEP, and that thought process of, it isn't just go up. It is, should we go up in this patient at this time? And is this a good thing, right? And so,
Eric, you kind of hit what I was thinking about earlier too, is we really, as RTs, have an opportunity to show that we're seeing these changes early and to be preventative versus being reactive.
Mhm.
And so I think that, again, is where if we can start identifying that early, we're not just looking at numbers to look at numbers, we're looking at them to see trends, to see changes that are needed. That is really going to be one of the approaches we can take to preventing VILI or reducing the events of it.
So let's go back to RT 101 then with ventilator management. Are we setting these up incorrectly? Are we setting PEEP at 5 and saying, I have medics that I teach and they're always like, well, 12, 500, 100% and plus 5. And I just want to say, shoot me, because why are we still stuck on plus 5? Should we be starting at 8 or 10? Should the setup of the ventilator, when we include PEEP, instead of being PEEPophobes, should we be able to set up the ventilator on a PEEP of 10 and then titrate from there? Or is that too much? Are we asking too much from the physicians or from the people that set up the vent?
Yeah, I mean, we could talk about PEEP for a long time, and there was never any literature to support the use of 5 of PEEP. This physiologic PEEP concept is mythical, and at least in my mind. And so, there was never anything to support the use of 5 of PEEP. I think there is some. Again, we should probably do one of these just on PEEP, but I think there's some data coming out that talks about BMI, and we certainly use transpulmonary pressures to set PEEP in people that are morbidly obese and more complicated, et cetera, et cetera. But I agree with you completely about the set it and forget it 5 a peep. I don't agree with it. And to be honest with you, when I see a patient for the first time, I never start them on 5 a peep, just out of spite for the most. No, I'm just kidding. Usually on 8. 8 is the new 5, and as far as I'm concerned.
I used to say if the patient's admitted for hypoxic respiratory failure, 10 is the new 5. That was for years I've been saying that, because even if you just look at the PPF, you don't even have to argue. You could just say look at the PPF IO2 table used in ARDSNet. If they're on hypoxic failure, I guarantee you they're not on 30 or 40% FiO2. They're probably on 50 or 60. And 10 is like the minimum you would find on the low PEEP table once they get to 50 centimeters. Like once they get to 50 of FiO2, 10 is a reasonable PEEP level like that. I'm pretty sure that's in the table. I'd have to look it up. But now if you're in the high PEEP table, you can get all the way up to 20 on 50 or 60%. But that's of course, I would suggest that you know more about the patient. Yeah. So, saying 10 is exactly. And I totally agree with Keith that if you're in a facility that has a lot of obese patients, you really need to be monitoring transpulmonary pressure, because you will find that you will need to set PEEP at a level that you are, and most people are, likely uncomfortable setting. And once you start doing that, it really opens your mind to that. Like these patients generally, half the time I call it pseudo ARDS. They're just significantly under PEEPed. You give them the right PEEP level, whatever is causing their respiratory failure, you get it resolved, you wake them up, you start weaning the PEEP slowly, get as low as you can. And I'm sure everyone here has extubated patients from PEEPs of 14, maybe higher, straight to CPAP or NIV, because you know that you can't wean them in that current state from high levels of or at low levels of PEEP. They're just going to fail everything. So but if they can tolerate CPAP of 14, comfortably on a ventilator, you could likely extubate them to CPAP of 14.
Yeah. So we only have a few more minutes left. Does somebody want to tackle Allison's question? I'll pull that one up because this is really relevant.
Yeah. So I can, so depending on your ventilator, you actually can on some ventilators, actually get a plateau pressure. And believe it or not, it actually tells you some valuable information. It tells you the true driving pressure that the patient is likely feeling. I'll quickly show up a graphic to display or to explain this, because Giacomo Bellani's published a lot of nice details on this. This is a study by him. Well, this is just a nice sort of like a research letter on ventilators that allow you to do plateau holds during pressure support ventilation. Here's an example of what you might see. If you do a plateau pressure at the end of the breath, when the cycle criteria is met, what can sometimes happen is your plateau pressure goes up and stays higher. This is actually the true driving pressure, because what this is reflecting is the elastic recoil of the lungs. So this is a esophageal pressure waveform. You can see this huge effort, and then when the ventilator cycles off, there's this passive recoil of the lung that is distributing pressure into the airways. So this is actually this represents more what the patient is getting rather than what we see. And they call this sort of the iceberg effect. We only see what's going on here. We don't see this unless you, of course, have an esophageal pressure monitoring. A patient with a really weak effort, when you do a plateau pressure, if your flow doesn't reach 0, for example, you're going to have a drop in plateau pressure. And then in this case, you have a patient with an effort that when you do a plateau, it just goes flat. Then it's just the patient is basically being met with the demand that they want. Now, some ventilators won't allow you to do this. Some patients also, if the value actually goes up over time, it's not a useful measure. You can't utilize that one because it means that there's active exhalation. The patient is forcing down if you do a plateau and it's continuing to rise. I have a nice blog post on this on the Toronto Center of Excellence in Mechanical Ventilation blog. So to answer your question, we don't know what the true driving pressure is unless your ventilator allows you to do this. There are ways to monitor the potential dynamic lung strain, and that's using a measure called the PIOC maneuver, which requires a single breath occlusion maneuver. This could, I think we discussed this in one of our maneuver presentations, Keith. If I'm incorrect, you can correct me. But the PIOC maneuver is a single breath occlusion that when you get the complete drop in pressure, you can put it into a quick calculation and it will tell you the dynamic transpulmonary pressure that's likely being generated with very good accuracy when it's high. So if you have a high dynamic transpulmonary pressure, there's a very good accuracy with that measure for high dynamic transpulmonary pressure, which is what we're mostly concerned about. So there are ways of doing it. The other thing, you could look at P0.1, which does reflect respiratory drive, but if they have a weak diaphragm, it can be a little deceiving because it might be a high P0.1, but maybe the diaphragm's not actually sustaining that contraction. So the potential for injury actually is dissipated beyond that 100 milliseconds that the ventilator tells you the value. But that's typically what you would monitor, would be P0.1 and the POC maneuver, which we covered in a previous presentation. And anyone can add, but that's essentially, like, tidal volume is a poor indicator because the patient might be getting, you could get high tidal volume with weak effort, and it's likely not causing much lung strain if your pressure isn't high on the ventilator. So there's a lot of, we sometimes don't know how to properly manage. And this is one of the criticisms for anyone that's been practicing long enough for the LOVE study. One of the things that was very difficult for respiratory therapists was like resedating a patient whose tidal volumes were too high when they were spontaneously breathing. We kind of felt like we were taking steps backwards a lot of the time because there was such a focus on minimizing tidal volume. In a current study that I'm part of, when patients are weaning, if the pressure support is less than or equal to 10 centimeters of water, they don't care what the tidal volume is. But they are suggesting a target of P0.1 less than 4. So if the patient's breathing with a normal drive and the tidal volume is high, but they're on low pressure support, they don't care. So yeah, the dynamic transpulmonary pressure, I'm going to put a link to my calculator because the references are also there. I'll put one to the measurement POC. So there's a reference right on this calculator. And then it also has the values on it that you could utilize for that calculator. And I can quickly demonstrate that actually right here. So we're past 1 minute, but if you're monitoring your patient on pressure support, and let's say the peak airway pressure is 16 and the PEEP that is set is, let's say, 8, and then you do an expiratory pause. Again, your ventilator has to allow an expiratory pause in order to do the POC. So on some ventilators, you may need to use the NIF feature, but you only want to capture one breath. So don't use the NIF value, do the NIF maneuver, and then freeze your waveform so you're only measuring the very first breath. But let's say you did this and the baseline pressure was 8 still, there wasn't any sort of auto PEEP that was registered. And let's say the drop was -12. So that was the lowest pressure. When you freeze your waveform and look at it, the lowest pressure was -12. This would give you a predicted PMUS of 15 and a dynamic transpulmonary pressure of 21. So I know in some current studies, so it's highlighting red because the accuracy above 15 is where it becomes more accurate. So I highlight it when it's above 15, but I only know one study that's intervening with this value, and it's 23 is when they're intervening, meaning they will try to do anything they can to reduce the drive of the patient because of the potential for lung injury that may be occurring.
Excellent. So we are at our time limit here. I mean, we could go on forever, obviously, but
yeah, we haven't even touched PCILI again, which
but
obviously is all part of this.
Respectful for everybody's time. We are going to do a VILI part 2 next month. And what we'll do is we'll go back, we'll briefly recap what we've already talked about. We'll talk about some of these maneuvers that these guys have just mentioned to evaluate for spontaneous effort, PMUS, and potential PCILI. We'll talk about
do recruitment potential. We could do recruitment potential.
And we'll talk about some imaging, a little bit more about EIT, and maybe some ultrasound and how that might help you to evaluate for recruitability, et cetera. And so we'll go from there. So sometime in March, be on the lookout for the invite. And just wanted to say thanks again to all of the volunteers, panelists here, and thanks to everybody who signed up and joined us today. You can go to our website, www.inspire-rt.com. And you can make recommendations, and that's where you would also sign up for our next discussion when we know what the date and time is going to be. So thanks again, everybody. Appreciate your efforts and your time.
Keith, real quick before you guys sign off, I would also add to what Keith said. Check out his YouTube channel at Keith Lamb RRT. A lot of these previous panel discussions that we've had are posted, along with some other stuff. And then I would say follow Keith on LinkedIn if you're not already. He posts a lot of great daily content on literature along with some other stuff. So definitely some good stuff there too. Thanks, guys.
Well, thanks, Andy.
Well said.
We look forward to more things like this in the future.
See you guys.
All right.
Have a good
Goodbye.
weekend.
See ya.